Hi everyone, I am Dr. Windsor. Thank you for joining me for another lecture on pharmacology. The contents of this lecture does coincide with the content covered in Chapter 15 of the textbook Pharmacology for the Surgical Technologist 5th edition that is co-authored by Howe and Burton. The goal of this lecture is to provide you with a better understanding of the concepts and best practices associated with the administration of general anesthesia in the operating room, and as always, provide some perspective regarding the role of the surgical technologist. So there are several key objectives in this lecture that I'm going to cover. So after completing this lecture, you should be able to define terms and abbreviations related to anesthesia. You should be able to list and discuss the indications for general anesthesia, as well as identify and describe the equipment used for anesthesia or to deliver anesthetics. You should also be able to explain the basic components of general anesthesia and list methods of inducing general anesthesia. Should also be able to define the phases of general anesthesia as well as explain the options for airway management. In addition to that, you should also be able to list steps in the process of endotracheal intubation, discuss the maintenance phase of the surgical procedure to include the concepts of awareness under anesthesia as well as muscle relaxation. You should also be able to discuss the emergence phase of the surgical procedure, including the process of extubation, and lastly, identify the major categories of anesthesia medications. Still more that you should be able to do in this lecture, after this lecture. You should be able to discuss intravenous induction agents, including their purpose and examples, discuss the purpose of analgesics and inhalation agents, as well as neuromuscular blocking agents. So clearly we have a lot to cover, so let's get started. So before we get too deep in the weeds, I want to review some important terminology that's associated with general anesthesia. The first term here, anesthesia, literally means without sensation, but in the context of general anesthesia, it indicates a drug-induced temporary loss of consciousness. The emergence phase, we're going to talk about all of the phases, but the emergence phase is the phase of general anesthesia when the patient is waking up from surgery. Research has shown that a patient's hearing is the last to go during induction, which means putting the patient to sleep, and it's the first to return upon emergence. And for this reason, we want to make sure that we are keeping noise and talking to the absolute minimum. We surely do not want to be banging around any instruments or playing any loud party music during this time because the patient can react significantly to loud noises. Very early on in my career, I was actually reprimanded by the anesthesia care provider for making too much noise counting my supplies and instruments with another circulating nurse during induction. So we want to respect the patient at all times, but during these times we really want to be as quiet as possible. So for those of you that have joined me for other lectures, you might remember that an emulsion is a drug form in which the medication is contained in a mixture of water and oil, and it's bound together with an emulsifier. An emulsifier is used to bind together two substances that typically would not mix. A common household example of an emulsifier is mayonnaise. A common medication used in general anesthesia that is an emulsion is propofol. Propofol is commonly used in the induction and maintenance phases of anesthesia or to provide sedation. The endotracheal tube, or ET tube, is a tube that's inserted into the patient's trachea or windpipe during induction, and this is going to allow us to provide ventilation for the patient. Remember, under general anesthesia, the patient's muscles are paralyzed and the patient doesn't have the ability to breathe on their own. So the ET tube is going to allow us to do that for them. The induction phase begins when medications are administered to initiate general anesthesia, and it's going to end when an adequate depth of anesthesia is reached and the patient's airway is secured. And again, we'll talk about each of these phases of general anesthesia in much more detail, but for now, just kind of reviewing some buzzwords here. Next on our list is fasciculation, right? So fasciculation is small involuntary muscle twitches just under the skin. So when the anesthesia care provider is inducing the patient, some of the medications are going to cause these small involuntary muscle twitches. And again, that is referred to as fasciculation. Lacrimation is the process of producing tears. Some of the medications given during intubation may increase tear production. Another phase of anesthesia is called the maintenance phase, and the maintenance phase is going to continue throughout the surgical procedure. So this phase begins when the patient's airway is established or the ET tube is secured into place, and then it continues until the surgical procedure is complete. And then lastly here, I apologize, a bit out of order, is the laryngeal masked airway, or LMA, which is an airway that is placed over the larynx. So it sits on top of the larynx. It does not go into the trachea. So we'll talk about each of these in a bit more detail as well. A few more terms here. Minimum alveolar concentration, also abbreviated as MAC. Now this MAC differs significantly from the term MAC that we learned in a previous lecture. Remember, MAC is also used to refer to monitored anesthesia care. Now in this situation, MAC refers to minimum alveolar concentration, and it is a measurement that compares the potency of inhalation agents at zero elevation, or sea level, which is referred to as 1 atmosphere of pressure. Opioids, which I have also discussed in previous lecture, is a term that has evolved to include any agent, whether it is natural, semi-synthetic, or synthetic, that produces the same effects as morphine. The last three terms I want to review are PACU, pre-induction phase, and RSI. PACU, remember, that stands for the post-anesthesia care unit. This is where we take the patient to recover from anesthesia after they leave the operating room. Now, the pre-induction phase begins in the preoperative care unit, so before they come to the operating room, but concludes in the actual operating room. And then lastly, RSI stands for rapid sequence induction, and this is a technique we use for patients who are at a greater risk for gastric reflux and resulting pulmonary aspiration. So to fully understand the concept of anesthesia, which literally means the absence of sensation, we need to know how pain is processed. Remember, whenever nerve endings are stimulated, like you see in this image here, there's like a poke to the hand, pain impulses. So nerve endings are stimulated, and then pain impulses are going to be transmitted from these peripheral nerve endings to the sensory and motor nerves. From there, the signal is transmitted to the spinal cord and then eventually arrives at the brain for interpretation. Now, not to get too much into nerve conduction, but sometimes, like when we touch a hot stove and our immediate reflex is to pull back, some of those reflexes bypass the brain altogether so that we can quickly remove ourselves from the stimuli. So in surgery, the patient does not have the ability to do any of this. So general anesthesia is a systemic or whole body state of anesthesia rather than just one part of the body. Remember that the administration of anesthesia interferes with our body's ability to interpret pain impulses. General anesthesia, more specifically, is defined as a drug-induced temporary loss of consciousness. And during this time, patients are not arousable, even when they're exposed to painful stimuli. So think about when you sleep. When you sleep, if your neck is in a weird position, a lot of times you'll wake up and you'll get into a different position, right? But our patients don't have the ability to do that. So as their healthcare providers, we need to make sure that we're also involved in their positioning and their well-being, and to remember and acknowledge that they can't protect themselves during surgery. So we have to be the ones that do that for them. So you might be wondering, how does the anesthesia care provider decide that general anesthesia is the best course of action for the patient? Well, the anesthesia care provider is going to take into consideration the requirements of the procedure. They're probably going to have a discussion with the surgeon. They're also going to take into consideration the needs of each individual patient. In a situation where there are multiple operative sites, such as with skin grafts or breast reconstructions or even autologous bone grafts, a general anesthetic may be the best course of action. Similarly, if the procedure is in an area where it's difficult to perform a regional block, such as the thoracic or abdominal cavities, then general anesthesia is typically going to be the preferred method of anesthesia. Surgical procedures that require a motionless field, such as retinal surgery, are often going to be performed under general anesthesia. So if the team suspects that the procedure will take a significant amount of time, then this may also be an indicator for general anesthesia. As I mentioned, another factor that drives the decision to use general anesthesia is the patient. Patient factors that might influence the decision to use general anesthesia include a few things: their age, their cognitive ability, and mental or emotional status. Children are almost never candidates for regional or local anesthesia, and because of this, surgery on these patients is typically performed under a general anesthetic. Cognitive ability may inhibit the understanding, communication, or cooperation during surgery performed under regional or local anesthetic. For example, Pap smears are typically performed in the office, but I have assisted with Pap smears in the OR on patients that have impaired cognitive ability. Patient's preference is also going to be taken into consideration whenever possible. For example, let's say we have a patient that's very frightened by the idea of a spinal needle, but they are in otherwise good health. general anesthesia may be an appropriate choice rather than the regional anesthetic. An anesthesia workstation is in each of the operating room suites, and it's typically found at the head of the OR table. If you have the textbook close by, figure 15.1 in your textbook shows an anesthesia workstation, but I've also provided one here for you on the slide. Some things that the anesthesia workstation consists of is manual or automatic ventilation systems, breathing circuits, oxygen and nitrous oxide pipeline hoses and backup tanks, vaporizers, pressure regulators, gas scavenging systems, and monitoring equipment. And if you want to learn more about or review the devices used in surgery for monitoring, you can revisit my lecture on patient monitoring and local and regional anesthesia. The monitoring devices, they have alarms on them, and they are set to emit a signal when readings occur outside of present parameters. So we don't want to get so focused. It's important to be focused on what we're doing as a surg tech, but we also want to remain aware of what these tones and alarms sound like, right? We're the extra eyes and ears of the operating room. So at one time, pain was thought to be caused by evil spirits or demons. So tattoos, jewelry, talismans, amulets, and charms were frequently used to frighten away these evil spirits or demons. And as time marched on, humans experimented with methods of anesthesia such as alcohol, mandrake root, which may sound familiar if you are a Harry Potter fan, compression of the carotid arteries to cause the patient to lose consciousness. And in some areas, situations, they even tried placing bowls over patients' heads and banging on them until the patient went unconscious before they did surgery on them. Acupuncture, cryothermia, using ether, which is a mixture of sulfuric acid and alcohol, and nitrous oxide were also used. Many of these anesthesia drugs had a reputation for producing unwanted side effects. Not to mention they were extremely toxic and explosive. Yikes. The use of chloroform became a hit in England in 1853 when the Queen accepted its use during childbirth. From these beginnings, anesthesia developed into the virtual branch of medicine that we know today. Today, though, we have many, many anesthetic agents that are effective and much safer. General anesthesia has 5 primary goals, and I want to review those. The first goal is to make sure that patients remain unconscious. This means that they are unaware and they do not respond to any stimuli. Secondly, we want to ensure that the patient is pain-free, and this is referred to as analgesia. Another goal is to ensure that the patient retains no memory of the event. We refer to this as amnestic. Also, the patient should remain immobile. And lastly, it's important that the patient maintains a normal cardiovascular function. So the 2 routes used to administer general anesthesia are IV and inhalation. A third method involves a combination of the 2, and this is referred to as balanced anesthesia. IV anesthetics are going to be administered directly into the bloodstream, whereas inhalation anesthetics are administered as a gas that the patient breathes in. Far less often, a regional block with a light general anesthetic is used. This method is appropriate for those patients that have major vascular procedures. This is going to enable the administration of a decreased amount of general anesthesia, which is going to help maintain cardiovascular stability and assist with post-op pain control. This technique is also used in select orthopedic and cardiothoracic procedures. When I had my hip replaced a few years back, I received a spinal anesthetic in combination with a light general anesthetic. So there are 5 phases of general anesthesia that we are going to learn about, and they include pre-induction, induction, maintenance, emergency, and recovery. And induction, maintenance, and emergence are the 3 intraoperative phases of general anesthesia. So we are going to discuss each one in a bit more detail in the upcoming slides. So as I mentioned previously, induction is the first phase of general anesthesia. Pre-induction is initiated as the patient is admitted to the pre-op holding area. It's going to include patient preparation, transport to the operating room, and pre-oxygenation of the patient. So during the patient prep, this is when the anesthesia care provider is going to perform the assessment of the patient's airway. After this evaluation, the anesthesia care provider is going to administer any pre-surgical medications that are appropriate so that they make sure that the patient remains as physiologically stable and calm as possible. After we transport the patient to the operating room, then the patient's going to be transferred over onto the OR table. Safety straps are going to be placed on the patient, and at this time, devices are also going to be applied to monitor the patient's vital signs. An oxygen mask is also going to be placed over the patient's nose, and this is referred to as pre-oxygenation. Now, the pre-induction phase is going to conclude at the point where the anesthesia care provider is ready to administer the anesthetic agents to the surgical patient. So then we move into the second phase, which is the induction phase. Induction is considered, as I mentioned before, one of the intraoperative phases. Induction is going to start when the anesthesia care provider administers the general anesthetic agents, and it's going to end when the patient's airway has been secured. Typically, induction agents are administered via the IV. However, in situations where we have a child in the operating room, they might receive inhalation anesthetics before the placement of the IV catheter to avoid emotional trauma of the patient and emotional trauma of us as well. So you might hear the term neurolept analgesia or neurolept anesthesia. These terms refer to a state that produces sedation and analgesia. However, the patient does not lose consciousness and can still breathe on their own, as well as respond to commands. It may also be referred to as a dissociative anesthetic state. So the anesthesia care provider is going to administer fentanyl, droperidol, and nitrous oxide. And this is an anesthesia method of choice in situations where the patient is having like a vascular procedure, because it has a minimal negative impact on cardiovascular and hemodynamic instability. Although the ST should have an awareness of this method, honestly, it is rarely utilized. So during the induction phase, extreme attention is given to the management of the patient's airway. Remember, no breath, no life. So the exchange of oxygen and carbon dioxide, or the respirations, is a vital function that has to be sustained in any surgical patient. And there's a few ways that we do that. I'm going to talk about them. For procedures that are short and don't require any muscle relaxation, the patient's airway may be managed with a mask, and that's that top image that you see there, where they kind of have that weird thing to like strap the mask to the patient's face. So the mask is going to be placed over the patient's nose and mouth, and then a combination of oxygen and inhalation agents are going to be given. So like I said, it's typically used for very short procedures where muscle relaxation isn't required. An example of that may be like a myringotomy with pressure equalization tubes. So let's talk about the second option. That is the second picture that you see there is a laryngeal masked airway. We call it an LMA. It may also be referred to as a supraglottic airway. So for selected patients undergoing procedures of fairly short duration, the LMA, which requires no laryngoscopy, laryngoscopic or muscle relaxation, is really useful for ambulatory surgical procedures. So procedures conducted in an outpatient facility where the patient has surgery and then they go home a few hours later, a couple hours later. They are available in a variety of sizes. So the LMA is the one that you see here. That cuff is kind of inflated and puffed up, but when they put it, insert it into the patient's throat, it is not inflated. So they're going to position it over the larynx, and then they're going to inflate that cuff, and that is going to kind of create a seal, and that's going to allow them to administer oxygen and inhalation agents. Now, there are some contraindications for using an LMA. That would include if we're doing procedures in the mouth. So oral procedures are a contraindication. Also, if the patient is morbidly obese, if they have a hiatal hernia, or any signs of gastroesophageal reflux disease, GERD, or low pulmonary compliance. So let's talk about the last option, which is endotracheal. And endotracheal requires the use of a tube, and you see it in the bottom picture there. And this tube is going to be placed between the patient's vocal cords and down into the trachea. Now, the ET tube is needed because many patients are inappropriate candidates for mask or LMA airway and need more precise airway control. The ET tube is going to allow for maximum airway control, and it is best for longer procedures. Many surgical procedures have long durations and require deep muscle relaxation or a lateral or prone patient position. So for this reason, we would choose to use the ET tube. Through that ET tube, again, same kind of deal. Gases and inhalation agents and oxygen are going to be delivered to the patient. Some variations of the use of the ET tube include rapid sequence induction, or if the patient is having nasal surgery, or if the patient has a difficult airway. So with rapid sequence induction, RSI, this is used when there's a high risk of aspiration. So let's say we have a trauma patient or a patient that has not been NPO, or we have a patient with GERD. these medications, anesthetic medications are going to be given, and then the airway is going to be quickly secured. Now, if we have a patient that is having oral surgery, then nasal intubation may be the best choice. So typically, the tube is going to be inserted into the nose with the use of a laryngoscope. And then lastly, if the patient has a difficult airway, then the anesthesia care provider might do something called an awake intubation. So after intubation, then the ventilator tubing is going to be connected to the ET tube or the LMA, and then respirations are going to be controlled by the ventilator machine. Sometimes, such as when the patient is having like a facelift, which is a rhytidectomy, as the ST, you may be responsible for or asked to help assist in draping the ventilator tubing. The tubing is draped and it's part of the sterile field throughout the procedure. And it's really, really important that we take great care in these situations not to disrupt the tube in any way, because as the surgeon kind of works around the face, you may be shifting positions, or you may be shifting the position of that ventilator tubing. So anesthesia is going to be on high alert when you're monkeying around with that ventilator tubing. So, please pay attention in those situations and act with great care. Lastly, it's important to remember that patients are highly reactive to noise during this phase. So we want to pay attention when we're setting up our instruments or having conversation or any of those things. So after induction comes the next intraoperative phase, which is maintenance. The maintenance phase begins as the patient's airway is established and secured, and it's going to continue until the end of the surgical procedure. It's kind of like when you take a flight somewhere, there's a lot of work to get up into the air, and then once they get up into the air, they're kind of on autopilot. So I guess this is kind of like the autopilot phase of surgery. And so during this time, this is when the surgery is going to take place, and the anesthesia care provider is going to administer additional medications as needed. They're going to be constantly monitoring the patient's vital signs. The right amount of anesthesia is a really delicate balance, and sometimes even under general anesthesia, if they're light enough, they might start to move or wiggle. In this case, we want to make sure that we let the anesthesia care provider know that that is happening. I was actually involved in a situation where we were doing a shoulder scope, a shoulder arthroscopy on this big kind of like football player type guy. And he was in the lateral position. I think we were repairing the labrum, and we had gotten started with surgery, and all of a sudden he starts to sit up in the middle of surgery, and all of us were laying on him, trying to keep him down while the anesthesia care provider was giving him more medications. Well, what we discovered was the anesthesia machine that was delivering the inhalation agents to keep the patient asleep was not working correctly. So we had to quickly switch out the anesthesia machines, and then everything went back to normal. But that is a pretty harrowing experience when the patient just starts to try to sit up during surgery. Awareness under anesthesia. Let's talk about that a bit. Awareness under anesthesia is a really disturbing phenomenon, and it's extremely rare, but nonetheless, it's a challenging problem in current anesthesia practice. The research indicates that on average, 0.1% to 0.2% of all patients undergoing general anesthesia have some form of awareness. And this doesn't sound like much until we put it into perspective. Approximately 21 million patients receive general anesthesia each year. This equates to an estimated 20,000 to 40,000 possible cases of awareness under anesthesia that may be occurring each year. Patients with a history of substance abuse and patients with chronic pain are at a greater risk for awareness under general anesthesia because they have built up a high tolerance to medications, right? Those that have a light anesthetic or are hemodynamically unstable also are at a higher risk. In addition to that, patients having cardiac or emergency obstetric procedures are also at a greater risk. As the surgical tech, it is best not to assume that the patient is unaware and unaffected by our conversations and comments during surgery. To decrease the chances of this awareness under anesthesia, midazolam is typically administered IV to provide enterograde amnesia so the patient doesn't remember anything. Monitoring devices have also been developed to predict awareness under anesthesia. However, it's important to note that a perfect system for preventing awareness under anesthesia has yet to be developed. Whereas short-acting muscle relaxants are given during intubation, long-acting ones are often administered during the maintenance phase of anesthesia. The extent of muscle relaxation is going to be dependent upon the surgical procedure. The depth of relaxation is going to be monitored with the use of something called a peripheral nerve stimulator. And this device is going to deliver a stimulus to a muscle group, and the response is going to be assessed. If there is little to no response, that is going to indicate the deepest levels of relaxation. If you want to learn more about the peripheral nerve stimulator, refer to my previous posted lecture, Patient Monitoring and Local and Regional Anesthesia. Ideally, muscle relaxation is present through the closure of the deep wound layers and then is allowed to wear off as the superficial layers are closed. Emergence. Emergence is the third and final intraoperative phase of general anesthesia. The emergence phase starts when the surgical procedure is finished, and it ends once the patient has been transported to the post-anesthesia care unit, the PACU, and a detailed report has been given to the PACU staff nurse, and usually the anesthesia care provider and the circulating nurse take the patient to PACU. So they're going to give like this handoff report to the PACU nurse. The surgeon back in the OR now, kind of as we are beginning the emergence phase, the surgeon's going to let the anesthesia care provider know that they're nearing the end of the procedure. And this is going to alert the anesthesia care provider to the fact that we are nearing the emergence phase, right? We're getting ready to come in using the taking the flight analogy. We're getting ready to land the plane, right? So as the name suggests, this is the time when anesthetic agents are going to be discontinued and allowed to wear off. Reversal agents may also be administered to shorten the duration of the anesthetic agents, and we'll talk more about those in a bit, but the patient is going to start to gradually wake up. Once the patient is able to maintain their own airway, then the items that we use, whether it's the mask, the LMA, or the ET tube, those are going to be discontinued and removed. And in my experience, the anesthesia care provider will often ask the patient if they can lift their head and continue to hold it up, which is called sustained head lift. So if the anesthesia care provider gets sustained head lift, then this is a good indication that the patient is awake enough to start breathing on their own. After that, we're going to put an O2 mask on the patient's face and administer 100% oxygen. the anesthesia care provider is in the driver's seat here, and they will be the one to determine if the patient is stable enough to transfer to the gurney and be taken to the PACU. Now, the recovery phase is going to begin after that report has been given to the PACU nurse. And as I mentioned previously, the PACU nurse is going to monitor the patient until they have determined that it is safe to discharge the patient home or to another area of the hospital. So now that we have a better understanding of the different phases of general anesthesia, I want to discuss agents used for general anesthesia. So there are several categories of anesthesia medication, and if you have your textbook, you can take a look at box 15.3 for a list of major categories of anesthesia medications. These agents are going to include induction agents, analgesics, inhalation agents, neuromuscular blocking agents, and reversal agents. Each type of agent contributes to a component of general anesthesia. So, for example, intravenous induction agents are going to produce unconsciousness, while analgesics are going to prevent the perception of pain. And like IV induction agents, inhalation agents are used to produce unconsciousness. In addition, they also prevent motor response to painful stimuli. Neuromuscular blocking agents are administered to relax muscles for intubation and the surgical procedure. And then reversal agents counteract the action of various agents administered during surgery. So next I'm going to talk about each of these in a bit more detail. So the agents used to induce unconsciousness are classified as sedatives or hypnotics. Benzodiazepines are sedatives that are used for induction. Some examples include Valium, Versed, and Ativan. Hypnotics used for induction include barbiturates such as thiopental, ketamine, etomidate, and propofol. These agents may also be used during the maintenance phase of general anesthesia. Prior to the development of propofol, barbiturates were the most commonly used agent for induction. Ketamine is very closely related to a drug called phencyclidine, or on the street, angel dust. Unlike other barbiturates, it also has an analgesic effect. When we administer ketamine, patients are going to appear awake, but they are dissociated from their environment. Ketamine isn't used very frequently because it can cause violent hallucinations and involuntary movements, as well as distort vision, auditory, and tactile sensations. But it may be used for painful dressing changes, debridements, or skin grafts. So let's talk a little bit about etomidate. Etomidate produces an unconscious state, but does not have any analgesic effects. It's often used in patients that have a compromised myocardial contractility. And this medication is going to be ideal for cardioversions and also in trauma patients who may be hypovolemic and unable to tolerate additional hypotension. And then lastly here, propofol. Propofol is often referred to as milk of amnesia because of its milky white appearance and its amnestic effects. It is an emulsion, like I mentioned before, and it's a combination of soybean oil, glycerol, and lecithin. As a result, patients that have allergies to soy or eggs should not receive propofol. Today, it's the most commonly used agent for induction, and it has an onset of about 1 minute. And it's interesting to note that propofol does not contain any antimicrobial properties, and because of this, Strict sterile technique must be used when handling it. For this reason, unused portions of propofol, as well as any IV lines containing the drugs, need to be discarded at the end of the procedure or within 12 hours. And if the medication has been transferred to a syringe, it needs to be discarded after 6 hours. So a second class of agents given during general anesthesia are analgesics. Analgesics, which are given during the maintenance phase, are used to prevent pain, and they fall into two categories, and those are natural opioids and synthetic opioids. Opioids are the most common analgesics, and they're defined as drugs that have morphine-like actions. So natural opioids, those are derived from the poppy plant. Isn't it beautiful? You can see it here. And those include morphine and codeine. Synthetic opioids are manufactured from chemicals that and those include fentanyl, alfentanil, sufentanil, and remifentanil. Now, fentanyl, interestingly, is 100 times more potent than morphine, and it's a big buzzword right now, fentanyl is. Alfentanil is about a quarter of the potency of fentanyl. Sufentanil is 5 to 10 times more potent than fentanyl. And then remifentanil is the newest synthetic opioid, and it's ultra short acting, and it is about 20 to 40 times more potent than alfentanil. The third class of general anesthetic agent is the inhalation agents. Volatile inhalation anesthetics are going to be bottled in and distributed in the liquid form, and then the liquid is going to be poured into the vaporizer on the anesthesia machine, and it's going to be converted to a gas or vaporized, and then that is how it's administered to the patient. Halothane was introduced in 1956, and it was the first non-explosive inhalation agent. Nitrous oxide is one of the most widely used inhalation anesthetics in clinical practice. And if you've heard of laughing gas, if you've ever been to the dentist and they gave you laughing gas, or they gave you some sort of gas to breathe that kind of took the edge off, that is nitrous oxide. The three most common volatile liquid anesthetics are isoflurane, desflurane, and sevoflurane. And like I said, these agents are breathed in. And after they are breathed in, they quickly diffuse into the bloodstream, and then just as quickly, they diffuse out of the blood and into the brain, which is the site of action for these guys. They're also eliminated from the body quickly, typically via the pulmonary, hepatic, and renal systems. And as I mentioned previously, these agents' potency is measured using the minimum alveolar concentration, the MAC. There are some disadvantages regarding inhalation agents, which include an increased potential for cardiovascular depression and lack of postoperative analgesia. Interestingly, nitrous oxide has a habit of diffusing out of the circulatory system and into closed air-filled cavities, such as the middle ear. So if a surgeon is doing a tympanoplasty, they might request for the anesthesia care provider to discontinue the use of nitrous oxide prior to the placement of the graft so that it doesn't get displaced or dislodged. The fourth category of general anesthesia agent is neuromuscular blockers. These guys are administered to relax the skeletal muscle for intubation and for surgery. Patients under general anesthesia may be unconscious, pain-free, and memory-free, but their skeletal muscles continue to respond to stimuli. And for this reason, muscle relaxants are given. There are two types: depolarizing agents and non-depolarizing agents. And to understand how they work, we really need to have a grasp of the process of muscle contraction. Our body, remember, is comprised of three different types of muscle tissue, and that is cardiac, smooth, and skeletal. Now remember, for a muscle to contract, it has to be stimulated by a motor nerve. And when the nerve impulse arrives at the neuromuscular junction, which is the gap between the nerve ending and the muscle fiber, which is also referred to as a synapse, a neurotransmitter called acetylcholine, or ACH, is released into the gap. Now, acetylcholine is going to diffuse across this gap, and it is going to attach itself to the receptor sites on the cell membrane of the muscle fiber. And that cell membrane is referred to as a sarcolemma. This is going to cause a reaction called depolarization. So, depolarization is when a change occurs inside the cell that causes the distribution of electric charges to alter. And this is going to leave the cell with a less negative charge inside than on the outside. So now it's more negatively charged around its cell membrane. Now, so this whole process causes a reaction called depolarization. So once this depolarization occurs, calcium channels are going to open and calcium is going to be released. And the presence of calcium is going to activate two types of muscle filaments called actin and myosin. You can see them on the screen here. So these two muscle filaments, actin and myosin, are going to engage with each other, and that is going to result in a muscle contraction. Now back to acetylcholine. Acetylcholine is now going to leave, and one of two things is going to happen. Either it's going to be recycled, or it's going to be broken down by an enzyme called acetylcholinesterase. And this is going to terminate the contraction. So depolarizing agents act like acetylcholine. They're going to bind to the receptor sites and they're going to cause contraction. And these contractions are going to be observed as small twitches that are just under the patient's skin, and this is referred to as fasciculation. As long as the agent stays bound to these receptor sites, then subsequent contractions are going to be prevented. Non-depolarizing agents, on the other hand, they act as acetylcholine antagonists, and they competitively block receptor sites, and they're going to prevent acetylcholine from binding, which is going to prevent contraction. So when the anesthesia care provider gives a depolarizing agent, we're going to see those fasciculations. When anesthesia care provider gives non-depolarizing agents, we are not going to see those fasciculations because it is going to prevent the contractions from happening. So neuromuscular blockers, whether they're depolarizing or non-depolarizing, they're going to relax the skeletal muscle for intubation and for surgery. Succinylcholine, or anectine, and a lot of times we call it SUX for short, is the only depolarizing neuromuscular agent that is in use. It acts similarly to the neurotransmitter acetylcholine, but its duration is going to be a lot longer. SUX has an onset of about 30 to 60 seconds and a duration of 5 to 10 minutes. Currently, there is no reversal agent for succinylcholine, so it must be allowed to wear off. Some adverse effects associated with succinylcholine include increased intracranial pressure, increased ocular pressure, and increased intragastric pressure. It can also cause muscle soreness post-op, right? Because it's causing these violent contractions, the depolarization of all the muscles in the body. Pseudocholinesterase deficiency is a lack of the enzyme acetylcholinesterase. And remember that acetylcholinesterase is the enzyme that metabolizes or breaks down acetylcholine. Individuals that have pseudocholinesterase deficiency are not going to be able to metabolize or break down succinylcholine. So because of that, the patient's going to remain paralyzed for a very long time. I can remember a situation, we didn't know, of course, that the patient had pseudocholinesterase deficiency, but after surgery, the patient was not waking up. And at this time, I was working at a surgery center where, patients come in, they have surgery, they go home. Well, we're like 2 hours post-op, we're still in the operating room, cases have been delayed, the patient is not waking up when they have this realization that the patient must have pseudocholinesterase deficiency. So what they had to do was, we were kind of in this medical complex where the main OR was very close by. So an ambulance came to get the patient and they transferred them to the main hospital and put them on the ventilator until eventually, but it takes hours and hours because they don't have this enzyme, or they don't have enough of it to break down the succinylcholine. So their wake up is very slow. Another thing regarding succinylcholine is that the FDA advises against administering it to children due to the possibility that they may have an undiagnosed muscular dystrophy. However, it is sometimes used in children where emergency airway control is necessary. There are several non-depolarizing agents that are used during general anesthesia, and they include pancuronium, atracurium, vecuronium, cystacurium, rocuronium, and mivacurium. As I mentioned before, depolarizing agents prevent muscles from contracting by binding to cholinergic receptors. So this prevents acetylcholine from binding. And these muscle relaxants vary in their onset and their duration. They can also have adverse effects on the cardiovascular system, including hypo or hypertension, tachycardia or bradycardia, and cardiac arrhythmias. It's also important to note that the effects of non-depolarizing agents can be reversed with the administration of a drug called neostigmine. So early on in my career as a surgical technologist, we had a patient from Germany. And you may not know this, but people from all over the world come to a small little town in Arizona called Eloy to skydive. And this patient was visiting for this reason, and while he was here, he was diagnosed with appendicitis. So we thought this was just going to be a routine case of appendicitis, but it turned out to be cancer that had metastasized to his liver, as well as several other abdominal organs. So instead of performing the surgery, we, kind of did what they call a peek and shriek. We looked in, we saw metastasis all inside the abdominal cavity, and we closed him up and we gave him a new diagnosis of terminal cancer with a few days to live. So These situations, while they're not common, thankfully, may result in a surgical procedure that ends sooner than we expected it to. So anesthesia care provider thinks that an appy is going to take, an hour, hour and a half, whatever that looks like, and they deliver the medication accordingly. And now we look and then we're like, we're done, we're closing. All right, so this is where the final agents for discussion come into play, and these agents are categorized as reversal agents. Reversal agents, which counteract specific anesthesia agents, are designed for surgical procedures that end sooner than expected. So as a result, reversal agents are going to differ depending on the anesthesia or the anesthetic agent that's been administered to the patient. So agents that are used to reverse the effect of opioids are going to include naloxone, nalmefene, and naltrexone. Flumanicil is administered to reverse the effects of benzodiazepines. And then for our non-depolarizing muscle relaxants, we have neostigmine and edrophonium. So that's it. We got through it. Thank you for joining another lecture on pharmacology. I hope that this contributed to your learning and that you come away with a better understanding of general anesthesia as well as the role of the surgical technologist. As always, thank you so much for your commitment to the field and to your dedication to honing your craft as a surgical technologist. Your patients and your community are lucky to have you. So until next time, take care. I'll see you soon.